Good afternoon, and welcome to the webinar, Epidemiology and Burden of RSV in Older Adults. I'm Angela Branch, an Associate Professor of Medicine at the University of Rochester and an infectious disease physician. And joining me today are two panelists, Kristen King and Joseph Miller, Dr. Joseph Miller. Dr. Miller is from the Henry Ford Hospital at Wayne State University in Detroit, Michigan, and Kristen King is joining us from SIU School of Medicine in Springfield, Illinois. Together, this will be the first webinar in a two-part series that addresses respiratory syncytial virus in older adults and high-risk individuals, and will help to elucidate both the burden of disease as well as risk factors that might be associated with severe RSV outcomes. This series was made possible through an educational grant from GSK. But it's important to note that all program materials was developed independent of the sponsor. After the presentation, we will have a Q&A session to answer your questions. So please do type your questions in the Q&A section and not in the chat on your screen, and we'll answer them as time permits. So let's go ahead and get started. To begin with, these are our disclosures. During this webinar, we'll talk about how to recognize the seasonal epidemiology of RSV disease. We will discuss the incidence of respiratory syncytial virus or RSV infection, including trends among specific patient subgroups. And we will also describe rates of hospitalizations and who to consider and test for RSV. The outline of the program is to begin with, we'll start with an overview of RSV epidemiology and seasonality, which is the part I will lead, followed by a discussion of the burden of diseases, and we'll conclude with testing considerations. That's the presentation portion of this webinar, and it will be followed by a Q&A session. So let's get started talking about RSV epidemiology and seasonality. So as many of you may be aware, RSV is an infection that occurs throughout life, with the burden of disease starting in young infants and then progressing with reinfections multiple times throughout life. It's the number one cause of bronchiolitis and acute respiratory illness, causing hospitalizations in young infants around the world. And in fact, young children under the age of 2 are almost universally all infected, again, by that age of 2. And then throughout childhood, you may continue to have additional infections, which usually might present with as a mild cold, or potentially an exacerbation of underlying asthma and even bronchitis or bronchiolitis with wheezing syndromes. And then as you progress into your adolescence, your young adulthood, and your middle-aged adulthood, it can again present as a reinfection with primarily colds. And then as we age, what we start to see is the more insidious respiratory illness. By insidious, we mean it can be lingering, it can be associated with more severe disease requiring hospitalization, and it can also lead to the exacerbation of underlying chronic cardiac and pulmonary conditions. So we know that it sort of has this bimodal distribution in terms of who it most affects and who it causes hospitalizations and other severe outcomes. In adults, which is the population for whom we're going to be discussing today, we think that some of that association with more severe outcomes and severe illness may have to do with what happens to our immune system as we age. Once you're infected and reinfected with RSV, you do have partial protection, but it's not sufficient to prevent you from becoming reinfected. And as we age, immune responses to having been infected start to decline. Particularly what we call our cell-mediated immunity declines, and that prevents us from being able to clear viruses quickly and may lead to more severe outcomes and severe illnesses. So RSV is an RNA virus, similar to influenza and SARS-CoV-2, the virus that causes COVID. It's an RNA virus. It exists in 2 subtypes, A and B, and both A and B usually co-circulate in any given season. It is a winter virus, so it tends to cause seasonal outbreaks in most winter seasons, where it might start around mid-September to mid-October. That's when you might start to see RSV circulating within your communities if you live in the Northeast. And then you continue to see cases rise to peak usually around late December, early January. And then you'll continue to see cases, but at decreasing levels through the end of April, typically, although it's sometimes possible for us to still see RSV cases in the late spring, in the midway. Altogether, it causes about 2 million outpatient visits in children under the age of 5. So again, causing a lot of disease, particularly in those young children, especially children under the age of 2 and young infants. It causes about 177 hospitalizations in adults 65 years and older. Again, highlighting sort of that bimodal distribution of when you'll see the most severe disease in the very young and the very old. And it does cause about 14,000 deaths in adults. In fact, 90% of all deaths due to RSV in the United States are in older adult populations, which is why for many years we've known that it would be good if we could to prevent RSV disease, particularly in vulnerable older adult populations. So let's talk a little bit about the seasonality and RSV circulation. Because we've been trending RSV circulation and doing surveillance studies around the world, and here in the United States, a lot of this work is done by the CDC for many years, as we have studied RSV and the burden of RSV disease. So pre-pandemic, what you would see is that RSV might start circulating in your local community, and usually in the Northeast here where I live, it starts around mid-October. That's when you'll start to see RSV disease. And you continue to see sort of a gradual climb in infections and hospitalizations related to infections through the end of December, beginning of January, which is when the peak is. And then you start to see cases decline. And by the end of April, RSV has more or less disappeared from most communities. It doesn't circulate very often in the summer, unless you're in very temperate climates. And then you might always have a little bit of RSV activity, though we don't do a lot of testing for RSV outside of winter seasons. But what happened during the pandemic is as we started to have non-pharmaceutical interventions like masking and social distancing, RSV essentially disappeared in 2020 and 2021. And then we saw in the summer of 2021, actually, this sort of brief spike with cases in children. And then again, we had very little RSV, the 2021-22 winter. And then this past winter season, 2022-2023, we started to see a resurgence of RSV again. One thing to point out about RSV is that some of what hampers our understanding of RSV activity within our communities, as well as the burden of RSV disease, is the fact that we don't often think to test for RSV. And I'm directing this specifically towards providers because, we start testing for viruses usually when we see flu activity within our community. RSV testing very often is duplex to influenza testing. And so it's not until we start to see a lot of flu cases and our local Department of Health or State Department of Health are telling us there's flu activity in our community and we should be testing for flu, do we start testing for RSV. But this is some data from local surveillance here in Rochester, which looks at when RSV season peaks compared to when influenza season peaks. So on the top graph, you're seeing influenza activity over 3 different years, 2018 to 2019 in blue, 2019 to 2020 in green and red, and that's for A strains and B strains of influenza. And then on the bottom, you're seeing RSV activity in Rochester again in the 2018-2019 in blue and 2019-2020 season. And as you can see, these graphs are superposed on each other, which means that each one of the horizontal tick bars represents a week. And so you can see the peaks of RSV and influenza season don't exactly overlap. In fact, RSV is peaking much earlier than influenza season, and RSV actually starts circulating about a month earlier than you'll really start to see flu cases. So historically, this has led to an underdiagnosis of RSV in patients because testing practices, which links RSV testing to influenza testing, which means you don't even start to test for RSV until you start to see for flu, and you might miss a month of RSV circulating in your community. And this is pretty important if you want to think about things like preventing the spread of RSV, particularly within households or within settings where you might transmit it to someone who's very vulnerable. This is a recent publication that actually shows very nicely the incidence of RSV hospitalization per 100,000 persons. And what it illustrates is that very nice sort of bimodal distribution of severe RSV disease. So again, what we're showing here is the estimated annual RSV attributable respiratory hospitalization rates by age. And so over here on the far left is the youngest age groups, those under the age of 1, and over here is the older age groups, those adults who are 85 years and older, and then each of these tick marks represents a different age bracket. Here, this line here would be where you're starting to see adult cases. And again, it's highlighting that there's really, that you see the most cases at the extremes of age, the very young as well as the very old. This study was also interesting because it qualified or quantified these RSV attributable respiratory hospitalization rates by income level. And so the light blue would be folks with a lower socioeconomic status. The yellow would be medium, and the red would be high. And you're seeing that the rates do differ a little bit by socioeconomic status, particularly in the very young. But again, it's still the same trend. You're still seeing the highest number of cases in the very young and the very old. So in general, as we talk about just how to think about RSV epidemiology and seasonality, it is a frequent cause, as I said, of respiratory infection in young children. Most children are infected by their second birthday, and you do see those very high rates in young children of hospitalizations as well. Healthy young adult populations, and even middle-aged adults, may be asymptomatic, transmitting the virus silently, and when they are symptomatic, they tend to have a more mild illness. But as we age, that's when we start to see, again, more severe illnesses related to RSV infection. And in adults 65 years of age or older, as well as adults who are middle age or older with underlying chronic conditions, can be at high risk for severe disease, which often leads to bronchitis or pneumonia, hospitalization requiring ICU care, mechanical ventilation, and even occasionally lead to mortality. So when you think about sort of the incidence in hospitalized adults, it does sort of vary per 100,000. So again, this is just incidence of RSV infection in hospitalized adults. If you were to ask me what's the incidence of RSV in adults altogether, you'd probably see a very similar incidence of just infection in all age groups, meaning all age groups get reinfected probably multiple times throughout their lives, and that risk for reinfection isn't necessarily higher as you age. What is higher as you age is the incidence of RSV-associated hospitalization. So even though the infection rates in 18 to 49-year-olds or 50 to 64-year-olds or 65-year-olds might be the same, the rates of hospitalization, as you can see, are quite different. And in fact, it would be 8 per 100,000 in young adults, about 33 to 63 per 100,000 in middle-aged adults, and then older adults, it can range from 130 to 255 per 100,000. And in fact, as you stratify by decade in those 65 years and older, it actually doubles with every decade of life. Here is another study that I think also defines the burden of RSV disease. It's a prospective study, actually 2 prospective studies that occurred roughly 15 years apart. The first study was actually conducted by colleagues of mine, Dr. Ann Falsey and Dr. Ed Walsh here in Rochester, and it was actually and still is considered the landmark study that established the burden of RSV disease in adults. Because when you think about RSV, again, you're not just thinking about RSV infection, but you're thinking about those who might be at highest risk. And so this study specifically prospectively enrolled healthy older adults, 65 years or older, as well as high-risk older adults, those 50 years or older with congestive heart failure, COPD, and asthma, and prospectively followed them over 3 winter seasons. That means they enrolled them when they were healthy, and then they followed them over 3 seasons to see who would go on to develop an acute respiratory illness, and if they could diagnose them with either RSV or influenza. And what we learned from this landmark study was that if you look at older adults as versus high-risk adults, the incidence of a symptomatic illness with RSV could actually exceed that of influenza. And so in the healthy older adults, they saw about 8% of them develop symptomatic RSV infections compared to only 6% who developed influenza. And in high-risk adults, 11% versus 6% in influenza develop a symptomatic illness. So this was one of the first studies that showed us that the incidence of symptomatic RSV infection in the community might actually exceed that of influenza in older adults and high-risk adults. A similar study was done about 15 years later and about 5 years ago now, called a rescue study in Europe. And it was also one of the few prospective surveillance studies where you enroll adults when they're healthy, and then you see who goes on to develop an infection. And they found really similar things, which is that in some seasons, the incidence of RSV infection in these at-risk adults might exceed that of influenza. And so what we learned from studies like these is that every year, 3 to 9% of older adults and 4 to 10% of high-risk adults will experience RSV disease. And again, that can sometimes be higher than even symptomatic influenza in this population. So these studies and some of what we've learned about the epidemiology have sort of elucidated both this burden of disease that was previously underappreciated, but also the risk for severe outcomes like hospitalizations in these higher risk populations of adults. So I think it's always good to think about the burden of RSV disease and RSV epidemiology in context of something that we already know. And so when I talk about RSV disease in adults, I always compare it to influenza, because I think that's something that people in our practices and our communities, as well as providers, are very well aware of, because we've been testing and vaccinating against influenza for decades now. So how does RSV compare to influenza when you're talking about disease burden in adults 65 years and older? Well, RSV causes 12% of all medically attended acute respiratory illnesses and accounts for 1.4 million outpatient visits in adults 65 years and older, 159 to 170,000 hospitalizations, and about 10 to 12,000 deaths yearly. These estimates are actually conservative. There's some estimates that estimates up to 14,000 deaths annually in this population. And overall, about 6 to 8% of all adults 65 years and older who do have an RSV infection will in fact die from that RSV infection. And as you can see, the outpatient visits are very similar to what we see with flu, as are the hospitalizations, as are the yearly deaths in this population. Now, keep in mind, we do vaccinate against influenza, but it just puts in perspective that the burden of disease that is associated with RSV is not insignificant, and that it's likely even underestimated because of lack of standardized testing. So now I'll turn it over to Kristen King, who will be talking to you more about the burden of disease and how it specifically presents.
Thank you, Dr. Branch. All right, so to move forward on to the burden of disease a little bit more for RSV. So as we know, respiratory syncytial virus is a pathogen that primarily targets the respiratory system and more specifically affects the vulnerable populations, as Dr. Branch explained, such as infants and older adults. The burden of disease is substantial, especially among the very young and the elderly. And we're going to focus on breaking down those numbers a little bit to better understand that. So again, as Dr. Branch said, in young children, RSV is a leading cause of lower airway, lower respiratory tract infection, often leading to bronchiolitis and pneumonia. The burden on families and healthcare systems is undeniable. But it doesn't stop there. RSV also exerts a considerable burden onto our adult population. In the United States alone, each year, approximately 200,000 older adults are hospitalized due to acute respiratory infections caused by RSV. In a single study at a large academic institution by Binder et al., it was found that a staggering 94% of older adults in the emergency department with RSV required hospitalization. Furthermore, when it comes to the severity, a study by Colosa et al. Demonstrated the RSV cases in older adults often necessitate intensive care. The need for ICU care ranges from 10 to 30%, highlighting the life-threatening potential of the virus. Additionally, 3 to 17% of these older adults with RSV often required mechanical ventilation, which only adds another layer of complexity to the medical care for these patients. This often is going to lead to longer length of stay as well. And then the overall mean adjusted hospitalization cost for these patients has been shown to more than double the mean hospitalization cost for influenza, with 38,828 for RSV versus $14,519 for influenza. So, and then again, kind of highlighting and breaking down a little bit more what Dr. Branch already mentioned a bit. So in adults age 60 years or older, there's an estimated of 700,000 to 2 million RSV cases annually. In certain studies. This highlights the extent of the problem, with a considerable portion of our older population facing the risk of RSV infection at between 2 to 10%. What's alarming is the mortality rate. A staggering 78 to 82% of all RSV-associated deaths occur in older adults aged 65 years and above. Population-based reports estimate a mortality rate between 6 to 8%, or in other terms, between 11,000 to 17,000 RSV-associated deaths in older adults each year. To further highlight the importance of these statistics, consider the findings of an observational retrospective study conducted by Kaiser Permanente Healthcare System, which involves over 15 large community hospitals in California. And this study revealed that the 1-year survival rate after admission for older adults hospitalized with RSV was significantly lower compared to those with influenza. Those numbers were stark, with a survival rate of 74.2% for RSV patients compared to 81.2% for influenza patients. So, further building upon the discussion regarding the burden of RSV and its impact on mortality, it is essential to highlight the specific subgroups that are particularly vulnerable to severe RSV infection. This includes individuals with lung disease, such as chronic obstructive pulmonary disease, COPD, and asthma, cardiovascular conditions such as congestive heart failure, coronary artery disease, as well as diabetes mellitus. Mellitus. Neurologic conditions such as kidney, liver, or hematologic disorders also contribute to an elevated risk. Furthermore, immune compromise, advanced age, as well as residing in a community living facility, all play a significant role in the increase in susceptibility to severe RSV infection. These subgroups constitute a substantial portion of older populations. It is important to recognize that RSV does not affect everyone equally. By acknowledging these specific subgroups, we can better target preventative measures, increase vaccination rates, and ensure early intervention for those who are the most vulnerable. So, expanding upon the discussion and on the burden of RSV and the specific subgroups most affected, it's crucial to consider the implications of the annual and seasonal incidence rates and their relationship to comorbidities. So again, just kind of diving a little bit deeper into where Dr. Branch touched earlier. So the annual incidence rate of our RSV, which stands at 37.6 per 1,000 persons per year, and the seasonal incidence rate at about 28.4 per 1,000 persons per year. when we break it down further, we find that there's a striking disparity in the incidence rates between adults with comorbidities and those without. So the incidence rate of RSV, acute respiratory infection in adults with comorbidities, face an incident rate of 37.6 per 1,000 persons per year, which is considerably higher when compared to the 6.7 per 1,000 persons per year without comorbidities. This striking contrast indicates that individuals with underlying health conditions are at a significantly elevated risk of contracting RSV-associated acute respiratory infections. Moreover, this data strongly suggests that not only are individuals with comorbidities at higher risk for RSV, acute respiratory infection, but they are also more likely to experience worse outcomes. And with the in-hospital fatality ratio of RSV positive older adults with comorbidities being 11.7% versus 1.6% for the general population. So it is also essential to closer examine the global perspective and the connection between specific health conditions and hospital admissions. Globally, 336,000 hospital admissions are attributed to RSV in adults 65 years and older. Of these hospitalizations, 11.4% were individuals with COPD, 7.2% had asthma, and 5.4% had congestive heart failure. These statistics highlight the overlap between chronic conditions and RSV hospitalizations. So now turning the presentation over to Dr. Joseph Miller.
Thanks, Kristen. Hi, everyone, and thanks for joining us. I am going to cover a little bit about testing, and I think it's certainly an interesting area because, just it seems like 5 years ago, we were rarely testing adults for RSV in any kind of systematic way. But I think hopefully some of you have experienced increased testing rates where you work. And I know where I work in Detroit, we've greatly expanded our testing for RSV. Although one point I'll make that Dr. Branch brought up is the fact that often we start our testing as flu season hits and still don't have that kind of reflex to consider RSV testing earlier in the season. I think as we overlap testing between COVID, flu, and RSV, hopefully that'll change over time, but I think it's still an area where there's room for improvement. So who to test is largely based on what we've already talked about. So we talked how age is a major factor for complications related to RSV, and we talked about comorbid conditions. So I'll just kind of highlight, based on these considerations, who to test. First of all, it's worth considering testing for any age group based on a few things. One is if they have severe symptoms. So if a patient shows up into my emergency department and has some form of respiratory distress, feels short of breath, has the potential to get hospitalized, we are certainly going to test that person for RSV anytime in the fall and winter or early spring. And largely because, one, as we discussed, it has prognostic implications, but also as we're deciding where that patient's going to go in the hospital and what potential exposure other patients may have to that patient and what kind of isolation precautions are in order, testing is really important. One of the worst things we can do is potentially not test, send a patient to a non-private room and potentially spread RSV to other potentially compromised patients. Certainly anyone that has symptoms and has a history of significant immune compromise should be tested. Top of that list would be patients with lung transplant, also patients with hematopoietic stem cell transplants, or other patients on significant immunosuppression. And then another group that I think, maybe we're not always aware of for RSV, but certainly we think about for flu or COVID-19 is residents of long-term care facilities. The rate of spread in facilities can be high. So even if a patient is well enough to go back to their facility or is being tested within the facility, knowing their RSV status can be incredibly important to avoid further spread of RSV within a facility. And that this is similar to the data we've already seen. This study out of from Bosco that all looked at data over long-term care facilities and looking at cardiorespiratory admissions on those long-term care facilities that all skyrocket, particularly during RSV season. And as you get older, as we already mentioned, to the latter decades of life, that rate goes much higher. And we mentioned already how age itself is a critical consideration for prognosis of RSV. And so really testing of anyone 60 and over with symptoms of a respiratory tract infection should be considered, particularly in patients with chronic lung disease, chronic cardiovascular disease, such as heart failure, or coronary disease, diabetes, CKD, chronic liver disease, immune compromise, or really any frailty that you would put that patient in a greater or higher risk group. And we've talked a lot about this already, but how do you consider when someone has more severe illness versus mild to moderate illness in terms of symptomatology? And some of this, I think, is common sense, but the mild to moderate illness in the younger age groups with no significant risk factors, may not need testing. Those patients will have runny nose, cough, sneezing, fever, poor appetite. But as we get into more severe illness, where testing is going to be more likely necessary, patients will complain of shortness of breath, chest pain, more substantial wheezing, or exacerbated symptoms of underlying disease. So, for instance, I saw a gentleman just earlier this week that had known severe heart failure with reduced ejection fraction, and he had presented with fatigue and shortness of breath that very much could just be his underlying heart failure, but the potential for RSV or COVID-19 in that patient was real. And so we certainly upfront tested that patient immediately to evaluate his potential viral infection status. Now, how to test? Certainly many years ago, many of you may be familiar with using rapid antigen detection, particularly in pediatrics. This is a common first step for testing sick children for RSV. But as polymerase chain reaction or PCR-based tests have become ubiquitous, and we've become very familiar with using them for flu and COVID-19, they've really become the ideal test for RSV in terms of having improved test characteristics and having more specificity and sensitivity for RSV. And so when available, they're the preferred way to test. And many of you may be familiar with using what are called multiplex tests, or a test that PCR tests that evaluate for multiple respiratory illnesses, particularly flu A, B, RSV, and COVID-19. And both nasopharyngeal or nasal swabs are often adequate and may differ based on what particular manufacturer you use. Certainly within our institution, we use nasal swabs for adults being tested for RSV. And one thing to note is that these tests are most sensitive, so you pick up the most number of cases within the first few days of symptoms. As persons goes into 5-6 days of symptoms, you may test them and have a false negative, even though they did have RSV. So the sensitivity is highest early in the disease process. One thing that's interesting about RSV, we talked about this bimodal distribution. And so you have the very young children that have high rates of RSV and its complications. And then children in general have close contact with daycare or schools to have all kinds of respiratory recurrent infections of RSV. Well, as there's actually been a rise in intergenerational homes in the United States, such that we're now a substantially higher proportion of Americans are in intergenerational homes compared to the 1970s. And so our older adults are more likely to be in contact with younger children, raising, again, a potential risk for RSV-related infections through contact with those young children. And one interesting thing is that as we've had a rise in intergenerational households, we've also had we also see that there's a greater proportion of non-white Americans are in intergenerational households. So why this can contribute to higher transmission is both from greater household density, again, the children less than 5, involvement in schools, as well as daycare attendance. And it's estimated that up to half of RSV transmissions are between household members rather than other people out in the community. And then again, as you see, this is data from the Pew Research Institute looking that if you look at the proportion of population, this intergenerational homes, Blacks, Hispanics, Asians, about a quarter of our patients are in intergenerational homes compared to white Americans. So thank you, and we'll open up to question and answer session and encourage everyone to potentially pose questions in the Q&A section, and we'll also answer between ourselves some Q&A.
Okay, well, maybe we can just start off a little bit by talking to our patient population, about our patient populations. I'm curious because we all have different subspecialties and areas of practice. So Kristen, you're in Illinois, right?
Mm-hmm.
And Jose, where are you again?
In Detroit.
Detroit. And I'm in Rochester, which is sort of a smaller city, not quite, but it has a character very similar to Detroit. So are you starting to see RSV at all in your communities? Are you testing for it?
Well, I can start. We are not seeing a lot yet, although I suspect we're getting right around that time where I expect to start seeing it. So testing is occurring. I think at least within my system, we often use these multiplex tests, and so we've been testing for COVID already for essentially that testing has never stopped, and so adding on RSV is simple, but yeah, I think yet to be seen when we'll start seeing a significant number of positive tests coming through.
Now, is it automatic, Joe? If you test for COVID, will you automatically get a test for influenza and RSV as well, or do you have to ask for it? Do you have to request
it? So it's interesting. We have a system where you do have to ask for it. It technically it's automatic, but the swab will actually run for all three: COVID-19, flu, and RSV. But until our lab starts seeing enough positive cases, they don't necessarily make it automatic. So for now, we have to ask for it until there starts being an automated trigger.
Yeah. Do you think that folks that work in the emergency rooms or providers and physicians like yourself have a fairly high suspicion for RSV during RSV season? Maybe more so than in the community practice, or do you still think there's a lack of awareness there?
I think there's certainly I think it became so publicized last year how impactful RSV was that it's starting to get more into everyone's mindset, but there's still a big lag there. We're so used to kind of not thinking about it in adults, and now with some of the data that you presented, Angela, and whatnot, I hope that it becomes more of a common mindset that this is actually, in many ways as important as influenza when we're evaluating particularly older adults.
Yeah. Yeah. And Kristen, you talked a lot about subgroups that are infected, particularly affected. Sounds like lots of people with chronic cardiac and pulmonary things, COPD, asthma, congestive heart failure. That probably fits well within your patient population as a respiratory therapist. Do you find that there's a lot of association with RSV and some of these groups of folks that come into the hospital that you might see that need oxygen therapy?
I would definitely say so. Sometimes we even have patients who have multiple respiratory viruses going on all at once. But the hospital that I work at is actually one of those who doesn't seem to test for it in adults probably nearly as often as they should. So we actually more so have the positive diagnosis for the little ones like pediatric and infants than the adults. But I think that we probably fall into that subgroup where we could use a little bit of improvement. So,
yeah. And
Angela, maybe I'll take, there's a question about testing from the Q&A, particularly about, is there a benefit between nasal versus, so anterior nasal swab versus the nasopharyngeal, or, the brain biopsy that everyone hates. That I did dig deep into that data, and for RSV, there's probably a slight increase sensitivity with the nasopharyngeal, though for adults the data is not very strong. So I think it's certainly reasonable to do both. And again, I can tell you that the payoff of having greater accepted testing favors the nasal, given that there's not a huge difference in sensitivity.
Yeah, I did a study once 10 years or so ago when I was still in training, where I looked at the yield of nasopharyngeal versus just nasal and throat swabs. And actually, a lot of times, by the time people end up in the hospital with RSV, they have lower respiratory tract disease, not upper respiratory tract disease. And so sometimes if you just test the nose, you might miss RSV about a third of the time. But I agree with you. People hate those nasopharyngeal swabs. And so the study we did is we actually used nose and throat swabs. So you swab the nose just in the nares hair, and then you swab the throat. And that kind of improves your yield a little bit. If you find like you have an elderly person scrunching up their nose and they won't let you pass that swab all the way back to the nasopharynx. And the other thing that people sometimes forget, and it's partly because the PCR tests aren't automated to do this, but it can be done, which is sputum is actually the best test. If you have somebody who can cough up sputum and they really have pneumonia or bronchitis, that's actually the sample you should be testing for RSV. So sometimes you can just swab that sputum and stick it in the tube along with your nose swab, and that might help too. So those are some tricks we find when we really think it's RSV or something viral, but we can't prove it. All right, another question for maybe Kristen, you can answer this. It says, given the known increased risk of RSV in those 65 years and older, especially those 85 years and older, why is there not a universal recommendation for RSV vaccine in those age groups? Okay, I can help you with that one too. Versus the current recommendation for MD plus patient discussion and joint decision, then RX.
I will defer that one to one of you.
Okay, well, it's a great question, Swen, and I actually would be in favor of a universal recommendation for adults. I'd probably say 75 and older for sure, and certainly adults in their 60s who have some of these chronic medical conditions. But I think when the vaccines were approved in June, and then the ACIP reviewed the data and made the recommendation that they currently made, partly what was driving that is that when you do a phase 3 clinical efficacy trial, it's always imperfect in the sense that you're only vaccinating 15 to 20,000 people, and then you give another 15 to 20,000 placebo, and you want that group to represent sort of every possible risk group that you're interested in high enough numbers. And if you've ever participated or done a clinical trial, you know how hard it is, particularly in the middle of a pandemic when these studies were conducted, to get frail elderly people who have a lot of medical conditions to come out their house and participate in study visits. And so some of the criticisms of the trials were that not enough adults in their 70s and 80s were enrolled, not enough adults with medical conditions, not enough adults living in long-term care facilities. And so there's the ACIP, the American College of Immunization Practices, felt that they thought that the vaccines would be beneficial and that they might prevent they likely would prevent hospitalizations and perhaps even save lives, but that more information is needed in the post-marketing studies that are going to be done of these vaccines in order to make a stronger recommendation that is either age or risk-based. And so it wasn't necessarily because we don't know that these groups should absolutely have prevention universally recommended and implemented if possible. It was more related to wanting to have more data to know exactly how to make a universal or a risk and age-based recommendation. And the ACIP didn't feel at this time they have all the evidence that they would like. So that's why they said that they would recommend the vaccines for adults 60 years and older, but they would prefer that recommendation be within the context of patients having a conversation with their doctor to determine if they have age or medical condition specific risks or some combination of risks for whom the vaccine would most be beneficial. And so that's sort of where we landed there. But in my practice, I am sort of recommending it for all adults in their 70s and 80s and all adults in their 60s who have chronic medical conditions like COPD and congestive heart failure. Okay, another question. I'm curious on your take about face masks and if wearing those for so long has increased the risk for RSV in adults, decreased or weakened our immune system. Joe, Kristen, either one of you feel
It's a good question. I think
answer that question. Yeah.
I mean, I can take a stab. It'd be interesting what you hear too. I think, in the end, face masks are kind of might delay us or they're preventing us catching some of the usual seasonal respiratory illnesses that occur, and it's more than just RSV and influenza and COVID-19. There's many other viruses that are seasonally going around us. And in the end though, our immune system has developed over many years of life and in some cases many decades of life. And so the immune system still maintains a memory of a lot of these viral infections and maintains that to fight them off in the future. And so a year of wearing a mask probably doesn't make a huge impact on your ability to fight these off.
Yeah. Kristen, someone in the chat wanted to know, are there any antiviral medications for RSV?
There is the Paxlovid. But do we use that one for RSV? You guys are probably a lot more familiar with those.
So we don't actually have approved therapy for all people with RSV. In the immunocompromised population, they do have something, but it's called ribavirin, but it's not recommended for other folks. I think that may be the one you were thinking of.
Yes,
and then,
thank you. Sorry.
Yeah, and then kids, there are 2 monoclonal antibodies to prevent infection. But yes, there is no actual approved treatment for RSV. Which is why we like to prevent it whenever we can, and why there's been such a lot of research and development around developing a vaccine. Okay, and then there's one more question about risks with taking the vaccine. There are always risks with vaccines. I can tell you a little bit about what they found in the phase 3 trials. So in the phase 3 trials, the vaccines were by and large well tolerated with very mild reactions. And so most of what they saw were things like a sore arm, some redness in your arm. There was some sort of body aches and headache and that sort of thing, most of which lasted for a day or so. There were 2 potential rare side effects that the CDC as well as the FDA and the companies are following and monitoring. One of those rare side effects is that there was an imbalance of something called atrial fibrillation, which is a heart arrhythmia. There were slightly more cases in the folks that got vaccine compared to those that got placebo. We don't know if it's related to the vaccine, and it was a slight imbalance, 10 versus 4 cases. And so it's hard to know what that means. But again, it's potentially a very rare side effect that is being monitored by the CDC and the FDA. And there was another rare event that occurred, which is that there were a few instances in both the Pfizer as well as the GSK vaccine trials where folks that got vaccinated developed a neuroinflammatory syndrome or inflammation of certain kinds of nerves. Of the 3 cases where they thought it might be related to the vaccine, all of them recovered or are recovering, but it's again another side effect that they saw that potentially might be related to vaccines. These vaccines very rarely. And again, the FDA and the CDC will be monitoring those as we implement the vaccine strategy. Okay, if I don't see any more questions, so if anyone else has any additional questions, that would be great. If not, I will ask for any final comments from our panelists. Kristen, I'll let you go first. Any take-home messages from your section about burden of disease?
I just think it's important for, older adults with comorbidities to, maybe kind of think of, I guess identify earlier if possible that they have this and kind of take those preventative measures to prevent getting it as best as possible. Even if it's just little things like focusing on hand washing and things like that makes a big difference.
Yeah. All right, Joe, any final thoughts for our audience?
I think one thing I've taken from learning more about RSV and even through this webinar is just the fact that we as clinicians we owe it to our patients to consider RSV more. As much as we consider flu, influenza, like we should start considering RSV and both testing and helping them navigate whether a vaccine is the right solution for them, depending on their age and comorbidities. And we have a lot to do as a medical community to bring this forward.
Yeah, thank you both. Yeah, so just some concluding remarks. As we have hopefully presented well, RSV is an important respiratory pathogen causing lots of significant disease every winter, both in very young children as well as in older adults. I totally agree with Dr. Miller that as clinicians and providers, it's important that we think about RSV when we think about things like flu and COVID, because that's how our patients are presenting, and test for RSV. I think you'll really understand burden of disease the more you have clinical suspicion for it, the more you test your populations for it, and then you can see what RSV does in your patients and understand why we need to prevent it whenever possible. It also will help you manage expectations for some of your patients with these chronic cardiac and pulmonary conditions. It's not uncommon for them after they've had an RSV infection to have many, many weeks before they return back to their baseline. And that means even being discharged home on oxygen for many weeks when they hadn't previously received oxygen. Again, as you're thinking about prevention and whether or not to recommend vaccines for your patient populations, remember some of those subgroups who are at highest risk that Kristen talked about, those with chronic lung and cardiac diseases, those with diabetes and neurologic conditions. Chronic kidney disease is an important risk factor. The vaccines weren't tested in immunocompromised patients, but again, consider whether or not it might be beneficial if it's within an age group for which the vaccines are approved. And then just to highlight what Joe said, test if you can. It's sometimes hard to do when you're in an outpatient practice. It's usually something you might have to send away to a laboratory, but it will help you know how to counsel your patients. It will help you know how to help them prevent other vulnerable members within their household or their family or community units. And again, it will help you know what not to do, like give antibiotics because they have RSV. So I think that's it. Someone did ask about the cost of the vaccines. The vaccines are ACIP recommended, which means that by law, they have to be covered by health insurance. If you have Medicare, they're being covered by Medicare Part D. If you're paying out of pocket, my most recent understanding is that the cost is between $350 and $375. But again, if you do have health insurance, by law, they should be covered by health insurance. So something to talk to your pharmacist and your doctors about. Okay, with that, I think we will conclude. Thank you so much for joining the American Heart Association for this webinar. An email will be sent to you with instructions on how to claim continuing education credit. Thank you, everyone.